Hello, my name is Jennifer Stransko, and I'm the Physician Engagement Associate for MAVEN Project. Thank you all for joining us today and our friends at Bart's Altadena Community Health Center hosting today's session, Approach to Patients with Joint Pain with Dr. Katherine Upchurch. Dr. Katherine Upchurch retired from the UMass Medical Center, where she was the clinical chief of rheumatology for over 10 years. She is professor of medicine at University of Massachusetts Medical School. Dr. Upchurch's abiding passions throughout her career has been the care of patients with all rheumatic diseases and medical education. She has been a leader in the Massachusetts Medical Society and the American College of Rheumatology and was selected in 2017 to be an ACR Master. In 2015, the New England chapter of the Arthritis Foundation honored her with the Marion Ropes Award, given to one area rheumatologist annually for excellence in arthritis care. And with that, it's all yours.
Thank you. I want to just start with to say that I'm delighted to be here and to be able to perhaps spark some passion in you about a field that I've remained passionate about, even though I'm no longer in the trenches. First, just my housekeeping. I have to go through the disclosure as shown on this slide, and also as mentioned that we are an accredited program, so you can get CME credit. Today, I'm going to be talking about the approach to the patient with joint pain, and I'm hopeful that at the end of this talk, you'll be able to distinguish between some different types of musculoskeletal pain, review and develop your own diagnostic approach to the most common causes of different types of joint pain, and also importantly, learn when to initiate a rheumatologic referral. In some cases, you won't need to, or otherwise, you might take the next available appointment. But sometimes also there are acute needs for referral, and I'll try to flag those for you during this talk. For the first introduction here, I want to start off with a case. So SA is a 45-year-old male who had a 2-month history of bilateral hand pain. He had 4+ morning stiffness, constitutional symptoms that included low-grade fever and fatigue, and he had a long history of IV drug abuse, including recently. Physical exam, which is a little bit abbreviated here, showed a lower extremity motley rash. He had some soft tissue swelling of his PIPs and his MPs of his hands, but no deformity. This is a picture of the rash that he had. You could see a maculopapular rash over the lower extremities, particularly distally with a purplish discoloration. Now you don't, nobody needs to speak out loud and say what the most likely diagnosis is, but just mentally remember what these options are, and we'll come back to this patient down the road. I get asked all the time, Doctor, do I have arthritis? Well, I think the very most important thing for people to understand, and you'd be surprised how few people do, is that arthritis is a descriptive word and it's not a diagnosis. Any one of more than 100 rheumatic diseases or conditions that affect the joints, the tissues surrounding the joints, and other connective tissues can cause what people typically associate with, quote, arthritis. And this is a CDC definition. As far as causes of arthritis, one or more than 100 conditions that affect joint structures can cause arthritis, and these include systemic and localized inflammatory and non-inflammatory diseases or disorders. So if you're confronted with a new patient in your clinic and you have maybe 35 or 40 minutes to begin to assess a patient who comes in and says, do I have arthritis? Or alternatively, I've got pain in my leg or pain in my shoulder. What is a framework that you might use to dissect what the possible causes could be? And that's what we're really going to be talking about here. First of all, it's important to recognize that the joint is a complex structure, including the covering of bone known as the periosteum, a capsule, which is a fibrocartilaginous capsule, as indicated here. Synovium, which is a very fine one-cell layer of tissue that basically surrounds the joint. And then a very important structure known as articular cartilage, which is depicted here. Um, in addition, muscles, which terminate into tendons, are part of the joint structure, and the tendon basically intersects with the joint capsule. So any one of these structures, if it's impaired in any way, could lead to pain that takes the patient into your office for your analysis. So it's important to think about what the pain driver is. So is the pain extra articular? Is it periarticular, which is around the joint, near the joint, or is it actually involved with the joint itself, in which case we refer to it as articular? And if it's extra-articular, we need to think about possible sources, particularly, and we'll focus on this again shortly, we need to think about referred pain from other locations, such as neurogenic pain, and one familiar to you all, cardiac pain, which produces pain often in the shoulder and the upper extremity. So there are a lot of different things that can masquerade as articular pain that we have to sort out as well. And how do we do that? Well, I think we have to have sort of a global knowledge of the field before we can begin to develop our own structure. And before I go into that, I want to remind you that there are mimics of joint pain, and I've mentioned them already, a couple of them already. So pain that is myotendinous, that is, it involves the muscle or the tendon, usually causes tenderness that's distant from the joint structure, and it corresponds to the muscle or tendon involved. And a good example of that is, say, biceps tendonitis, which causes what some people might interpret as shoulder pain, but in fact, it's the insertion of the biceps tendon onto the shoulder joint. Neurogenic pain is another example of pain that often is thought to be joint pain, but there's usually no tenderness at the site of perceived pain. And additionally, if you do provocative maneuvers that result in nerve stretch, such as the straight leg raising sign, you can duplicate pain that the patient's experiencing. And finally, the distribution is often related to a dermatome or a myotome of a specific nerve root or a peripheral nerve. An example of this might be carpal tunnel syndrome, in which a patient develops pain in the hand in the distribution of the carpal tunnel. And then the other important things to recall is that you can have cardiac sources of pain. And this is, I can't tell you how often this is missed. Patients develop pain which is radiating down the arm. And in one case I saw recently, it was a friend of mine who ended up having urgent revascularization. She was a youngish woman, had never had any cardiac disease, but if you just listen to her, she had pain radiating down her arm when she walked uphill. And it turned out she had a three-vessel disease when she had a cardiac cath. Vascular, particularly, and that's cardiac vascular, but other vascular problems such as lower extremity claudication can cause buttocks and leg pain. And then it's not uncommon for perineoplastic disease or even neoplasms to present with pain that could be conceived as joint pain too. So you really have to try to think a lot in the broad way about what could be causing a patient's symptoms. And so how do you approach this? History is absolutely the most critical part in terms of sorting out what could be causing the patient's problem. I've never taken a poll about how many patients are correctly diagnosed based on history alone, but I'll bet it's approaching 80%, maybe even 90% sometimes. And so I would really encourage you all not to blow through the history and don't discount it. And then the second thing is believe the patient when they tell you something hurts, uh, and believe uh, how they describe their complaints. And also, in particular, as indicated on this slide, think about what kind of questions you might ask that can um, further elaborate what the problem is. So, if a patient has pain on specific motions of a joint, well, that suggests that it is an articular problem. If a specific joint either has been or is now red or warm, well, that suggests that it's an articular problem. It's very important to know if a patient comes in complaining of knee pain, well, are there other joints involved? Because that takes it from a monoarticular process and moves it into a oligo or polyarticular process. And the other thing that it's important to establish historically is the pattern of pain. Is it continuous? Does it come and go? That sort of thing. Is it acute? Has it been there for months? Now, along the way, I'm going to flag some things that are important for you to remember. Um, First is that acute mono or oligo, that's just 2 to 3 joints, articular joint pain is a red flag. By red flag, I mean that could, not necessarily is, but could be caused by a dangerous condition, such as an acute intra-articular infection. And that's the thing that is the most challenging if you miss it. So pay attention to that as far as a pattern of pain. And a thorough history, just to reiterate, will frequently give very important clues to the diagnosis. So when you take a history, I'm not going to read all of these items because you can read them yourself when you get the slide deck. But these will give you hints about what could be causing the problem. So as far as type of onset, a hyperacute post-traumatic onset is typical of an acute fracture or an internal derangement, or even a hemarthrosis, such as in the setting of hemophilia. Acute, which is not immediate, it's hours to days, is typical of inflammatory arthritis, such as due to crystals, infection, or an inflammatory chronic disease. Some delay after trauma could also be a hint that what you're dealing with is a crystal-induced disease, such as gout or pseudogout. Certain conditions cause migratory joint pain. This is typical of gonococcal arthritis. And in the old days, we saw it frequently in rheumatic fever, which fortunately we don't see too often anymore. Insidious, nonspecific, it's seen in many inflammatory and also non-inflammatory conditions, so it doesn't really help you very much. But it's important to ask. Ask the patient, get the patient to describe to you what's going on and take notes. And then when you write up your note, include that in the history. So the pattern of pain, if it's present at rest, it suggests there may be a true inflammatory process. If it's only with activity, that's likely to be mechanical, such as, let's say, osteoarthritis of the hip. When you walk upstairs, it hurts. You can have joint pain you can have, well, arthritis in the absence of any pain, and that suggests a Charcot joint, which is a neuropathic joint, in which case the patients not uncommonly destroy their joints, the involved joints, because they can't feel due to denervation that they are. Precipitating factors, blunt trauma, repetitive trauma, penetrating injuries, all of these things need to be asked about. And also, it's interesting if you have a patient and he comes in with a red hot swollen ankle or foot, and he says, well, you know, I had a few beers last weekend. It's never happened before, but a few days later, this is what happened. Well, that's very suggestive of possibly gout. And we see this all the time in hospitalized patients who come in and they have their surgery, and then they get, due to probably related to intravascular volume shifts, they develop gout or pseudogout, but gout would be more common. Often there's some medications that you might be suspicious of. If you have acute onset, hyperacute, well, patients may be on Coumadin or one of the newer agents such as Eliquis. And this predisposes to hemarthrosis, particularly if there's injury. If you have a more chronic or subacute problem and the patient has a history of high-dose steroids, they could have avascular necrosis, or even very high dose, they could be immunocompromised and have developed a septic joint. Patients who take particularly thiazide diuretics are susceptible to hyperuricemia and gout. And patients who are immunosuppressed often may develop in the setting of bacteremia, hematogenously spread septicemia involving the joints. If a patient has a history of a tick bite, that's important to know because obviously, particularly in the Northeast, Lyme arthritis is of concern. There is a syndrome of post-vaccination rubella. Also, if a patient's been exposed to parvovirus, like adults, for example, whose kids may have parvovirus, they can develop it, and it's a little bit of a different disease in adults than kids. Patients with other viral diseases such as Hep B, Hep C, even patients who travel to the Caribbean can develop chikungunya or dengue disease. All of these things can be associated with generalized arthritis. And then finally, as I said, a local joint pathology such as a puncture wound can puncture right through that synovial membrane and introduce germs into the joint, leading to a septic joint. The other thing is you can use age and gender as guiding you to particular predilections. So a sexually active individual of any sex is possibly more likely to have gonococcemia than not. For some reason, and I don't know why the epidemiology may have changed, I don't think this is quite as prevalent as it was early on. Frankly, the oldest patient I've ever seen with documented gonococcal multiple septic arthritic joints was 65. And she was a woman, and she developed gonococcal arthritis from her husband, who was a carrier of this, and he had never been treated, and she was sick. But fortunately, we were able to make the diagnosis. But I think if you have to think about that, if she's sexually active, or if her husband is or somebody that she's going out with or seeing is sexually active, it could be. Middle-aged male particularly drinks beer or other alcoholic beverages, gout. Elderly females, more commonly than males, can develop what we call pseudogout, which is a manifestation of CPPD or microcrystalline arthropathy due to calcium-containing crystals. Red flag, septic arthritis can occur at any age, so don't rule it out if you see an angry joint, although many times the angry joint in a man will be gout, but always consider septic arthritis and treat it as if it's an urgent problem. Premenopausal women, this is a little tip, virtually never get gout unless they have renal failure. And perimenstrual females have a higher incidence of developing gonococcemia in the perimenstrual period and expressing their joint pain. So these are just little tips. It's very important to take a travel history, considering endemic areas for Lyme disease, Zika, chikungunya, dengue fever, other viral infections. Now, when you've taken a history and you've done a thorough joint examination, you may be able to start telling a more complete story, and you may be able to nail down the type of arthritis that you think the patient may have. And as I mentioned, there are many different types, but in general, we rheumatologists break up the type of arthritis that patients present with into two broad categories: non-inflammatory and inflammatory. Included in inflammatory is the septic category as well. So non-inflammatory is a disease which is more subacute or chronic, and it's the most common. It's the kind most people's grandmothers have. Uh, I'm a grandmother. In fact, I've got a little bit of it myself. There are typical joints that are involved, which we'll see subsequently, but it can cause most commonly involvement of knees and hips. It's post-traumatic way down the road. So somebody who played football or basketball is almost always going to develop this problem. And yet there are patients who've never had an injury, who've never had a problem, who develop osteoarthritis as well. And by knowing that it's subacute and it's chronic, by knowing that certain joints in the hands are involved as opposed to others, which almost never are, um, and by knowing a previous history of trauma, by knowing that it involves, particularly in the hands in females more than males, you'll get a good idea of which group of patients you see do have osteoarthritis. Now, a smaller proportion of the patients who walk into your office complaining of joint pain are going to have inflammatory pain, but this is a group I think you need to focus on rather than assuming that most people have non-inflammatory and discounting the possibility of inflammatory. Now, inflammatory arthritis can be acute, it can be subacute, or it can be chronic. Acute would be days to a few weeks. Subacute would be a few weeks to slightly longer. Chronic would be months, weeks to months. So included in the inflammatory group would be rheumatoid arthritis, and we'll be talking about that in a minute, briefly. Uh, a condition called reactive arthritis, which is associated with acute or chronic diarrheal illness, with other conditions such as psoriasis. And by the way, if you want to learn any more about any of these, stay tuned because I'm going to be giving talks all through the year, including on these particular illnesses. And then we've mentioned the crystalline arthropathies and other inflammatory diseases such as lupus, um, uh, and then the viral syndromes that I mentioned to you as well. And particularly arthritis with regard to viral syndrome may be a prodrome. Hepatitis B comes to mind. It's not uncommon when you see polyarticular inflammatory arthritis in someone who's at risk for hepatitis B, that's the first presenting symptom. So, as I mentioned in this pearl, inflammatory arthritis can be a prodrome or it can be simultaneous symptom of infection, including viral and bacterial. And early diagnosis of inflammatory arthritis is really important for two reasons. One is if it's possibly septic, you need to initiate antibiotics appropriately immediately after you've made the diagnosis. But also with regard to the more chronic diagnoses, such as rheumatoid arthritis, the earlier you can define it, the sooner you can be aggressive with regard to treatment. And we now have so many different ways to treat it that we can virtually suppress disease in almost every patient and prevent many of the long-standing sequelae that used to plague us in the earlier parts of the in previous years. Now, if you have a patient who has pretty much, if you have any questions whatsoever about the diagnosis, in particular, if you think the patient has inflammatory arthritis, I would argue that because rheumatologists are experts in diagnosis and because it's often helpful, and if you can take some fluid out of a joint and look at the constitution of the joint fluid to make a diagnosis, and finally, if you want to institute the appropriate treatment early in the onset of the problem, it's helpful to get patients into a rheumatologist. Now, for those of you who are in the trenches and maybe have called a rheumatology office and they say, oh, well, we can see the patient in 6 months or 4 months. I want to urge you as the patient's advocate, don't take that from the front office barrier. Simply move beyond the front office, speak directly to the rheumatologist, and have in hand why you think it's important that this rheumatologist see the patient ASAP or within the next few weeks as you determine it's appropriate. So I find more often than not, there are a lot of offices in which patients have seen the physician, and then the physician, as far as disposition, says refer to rheumatology. And so one of the office staff actually places the rheumatology referral. There's usually very little information and there's no patient advocacy. And so this is an opportunity I want to take and to urge you all to, first off, think of yourself as a patient advocate. Because if you can't advocate for your patient and you can't get the patient in, no one can. And so it's important to think about your role in that regard. So I also want you to really think about systemic features, and these are just some others that you can review later on. Now, morning stiffness is a really important question to ask. It implies, if you have it for more than 30 minutes, that there's a true inflammatory process or even infectious. But it's the hallmark of, say, rheumatoid arthritis is morning stiffness. And we've talked about some of these other things: rash, conjunctivitis, urethritis, associated symptoms and findings that might be helpful as far as clues. I want to talk to you a little bit about the physical exam. Um, this is, I think, about the halfway point of my talk. So I'm going to really be flying because I don't want to go way over. Um, this is a patient who was out at the beach, and you had no history of any specific rheumatologic complaints. And she showed up with this rash. And I'm sure most of you are aware that patients with lupus have a typical history often of photosensitivity. And this is a great example of photosensitivity where the bathing suit line protects the area that is not exposed to the sun, but the rest of the back and the body, upper extremities, and presumably in the lower extremities too, were just torturously involved with this erythematous rash. Um, Lupus can also cause a bullous rash, so it's important to go over the exam. Um, but other rashes are associated with arthritis. This is a patient with psoriasis, and this is a papulosquamous scaly eruption that often occurs over the extensor surfaces, particularly the elbows and the knees. Um, this is interesting. This is a gonococcal uh, vesicle and a pustule. In this setting, the patient presumably had gonococcemia. So she had septicemia or he had septicemia. And this is actually a little septic vasculitis, is what it is. There are other forms of gonococcal disease, but these are little septic cutaneous lesions. And sometimes you can actually get, if you puncture that little vesicle, you can get some gonococcal organisms to grow, but they're very difficult to grow, very. Now, I've already mentioned, and this is a familiar if you were paying attention, uh, this is a patient who has uh, what's called a leukocytoclastic vasculitis. Like arthritis, that's not a diagnosis. That is a description. And it's a description of purpuric, basically bumpy lesions that often involve the lower extremities, but can be present on upper extremities and are associated with a bunch of different diseases. But if you see this kind of rash, this is very important to get a patient in to see a rheumatologist ASAP. Because if you can't be sure of what the problem is, it could be something very serious. This is another example of several patients who had leukocytoclastic vasculitis. The patient in picture A had a more, and B had very superficial disease, whereas the patient in C had coalescent lesions that went slightly below the epidermis and dermis and led to some local skin cutaneous loss. And then you can even see leukocytoclastic vasculitis involving a little bit larger lesions leading to necrosis. And you can see that in this exaggerated case here. But basically, leukocytoclastic vasculitis is um, lower extremity, particularly purpuric, purplish, lumpy, bumpy type rash that has some feel to it and can be associated with a variety of diseases. In particular, we see it and have seen it more recently in patients with cryoglobulinemia, which we see in association with hepatitis C. Um, and it's actually the immune complex that is settling into the vasculature in these patients with this disease. Now, if we go to the joint exam after we've looked at the skin exam, and that's what the last few slides I showed you were, it's not all inclusive, but these are just examples. This is a patient who has obvious disfigurement of her joints. But if you look, there's a certain pattern to this joint. First of all, just looking at it, I can tell that those joints are very hard and they're hypertrophic. So this is bony enlargement of these joints. And I can also say that there's no involvement of the proximal row of the joints, and probably not the wrists either. So this involves PIPs and DIPs across the board, but there's no involvement of the proximal rows, the MPs. So this is typical osteoarthritis. And it's not uncommon for you to see people whose hands look like this and they've never seen a doctor because after a while they just stop hurting. They aren't very functional, but there's not a whole lot you can do about this except for observe and diagnose and make sure you're not missing a specific diagnosis. But this is characteristic and it happens much more commonly in women than men. This is a patient, in contrast to that patient, whose hands looked fine, but she came in complaining of knee pain. And what the most striking things that you see on this exam are that she has an alignment deformity, which we call a valgus deformity. And because it's in the knee, it's a genu valgus deformity. And it appears that she has an effusion also, which is intra-articular excess of synovial fluid. And this is a characteristic finding that one would expect in a number of different conditions. But if this is chronic, if there's no warmth, and if it's been going on for weeks to months, this is most likely osteoarthritis. Now, so just to recoup, osteoarthritis is associated with tenderness in involved joints, usually bony swelling, pain on motion, loss of motion, and the particular joints that are involved, hips, knees, thumbs, particularly the first carpometacarpal joint, distal hand joints, DIPs more so than PIPs, not the MPs, not the wrists, and this characteristic malalignment that you saw on those previous slides. Now, this is in striking contrast to a patient with rheumatoid arthritis, in which you often see fusiform swelling. And if you kind of shut your eyes and imagine what these joints feel like, they feel squishy. That's the best way I can describe it. And that's what they look like too. But notice there's no involvement in the DIP joints here. And there probably is some involvement in the MP joints, although we would have to actually feel those joints to determine that. So a PIP joint involvement is kind of a swing joint in terms of osteo and rheumatoid, but they feel very different. And the type of hypertrophic change that you see with osteoarthritis is simply not there unless you have a mixed picture, which you can have in older individuals. Now, this is a patient who actually has a synovial effusion, but you don't see this on a characteristic malalignment abnormality except for in very advanced stages. And you see a little bit of overlying erythema and some warmth. This is a patient who has osteoarthritis, rheumatoid arthritis of his knees. So on exam with rheumatoid arthritis, you do see tenderness in involved joints. You see synovial, but not bony swelling. You see pain on motion, loss of motion, may not be present. And exaggerated cases, particularly early, a patient will complain of severe pain when they wake up in the morning, and by early afternoon, they don't have any pain, and often they have no findings. So that's a situation where you have to listen to the patient and believe the patient to make the diagnosis. Again, the particular joints that are involved are the PIPs, the MPs, not the DIPs, but also multiple other joints, often wrists, elbows, shoulders, uh, ankles, knees, MTPs, any synovial based joint, including TMJ joints, sometimes uh, cervical spine joints. And there are characteristic deformities in very late disease, but I think people walking into your office for the first time who've not been diagnosed are not going to have those characteristic deformities. Um, Now, I want to move to a couple of other things. This is a patient who has uh, extreme discoloration extending beyond the joint margin. So the joint margin is basically here, very close to the joint. And you see, oops, sorry, you see this erythema extending way beyond the joint margin. And when you see that, you have to be concerned about septicemia with a septic process that's periarticular, possibly interarticular, that it's spread to have cutaneous involvement, or even sometimes gout. Um, it's a little tricky how you approach this because you don't want to stick a needle into an infected bursa or through infected skin into the bursa because you might introduce more infection than you by doing so. So basically, you have to treat this for a septic process, and then if it doesn't get better, you can assume that you've sterilized the skin and you can go in and aspirate and find out what the organism is. Although most of these organisms in uh, normal patients are staph. Um, Now, this is another example of a bursa. And this is the olecranon bursa over the elbow. And this is not infrequently due to septic processes because the elbow, when you put your elbow down on a surface or you bump your elbow, often there can be direct inoculation of organisms. Now, either of these could be due to gout as well. And these would be examples where I would refer definitely urgently to a rheumatologist because the rheumatologist will know um, how to treat initially and when to aspirate and take it from there. But this is the kind of thing where you call an office and you say, I need you to see this patient today and if tomorrow, and if you get a big fat no, send them to the emergency room because that will accelerate uh, de novo for sure. Now, there are a lot of ways that you can get um, assistance, uh, but you're not going to get any of these results back right away. So I want to stop here and remind you that you can get a pretty good idea of what's going on with your patient just by taking a detailed history and doing a doesn't have to be a painstaking joint exam, but a good joint exam and a physical exam too. I mean, patients with undiagnosed valvular heart disease can have SBE or ABE. And if you're the first person to have heard a heart murmur and a patient has, a septic embolus or has, um, a septic joint, you may save a life. So just be a good doctor when you see these patients and think about all the different possibilities. But then you can turn to some diagnostic testing as well. So these are some tests that we would want to get on virtually anybody who comes in. The CBC and Chem12. I think the SED rate, C-reactive protein. Some places now are relying almost exclusively on C-reactive protein. I always used both. Don't ask me why, it's just habit, I guess. And these would be somewhat elevated if there's inflammation. They'll be off the wall if there's infection. Um, and the other serologies that you might consider would be hepatitis C testing, hepatitis B testing, uh, also testing for rheumatoid factor, anti-cyclic citrullinated peptide, which is associated in many patients with rheumatoid arthritis. Less specific is the rheumatoid factor, but anti-CCP is highly specific, and both of them together are the most specific. 10% of rheumatoid patients are seronegative. Um, and also, you should be aware that there's a high incidence of false positive rheumatoid factor in patients as they get older. Um, 2 words about an ANA, and again, I'll be talking about lupus later on, and we'll spend a lot more time with this. The presence of a low titer positive ANA is very nonspecific unless it accompanies a highly suggestive history and other serologic abnormalities. Now, moving on, we often would order a uric acid level. You should be aware that an elevated uric acid level does not, that's not mean that a patient has gout. It means they're at a higher risk of gout, but you can have a diagnosis of acute gout in the absence of hyperuricemia, and in some cases, even with low uric acids. Uh, if you suspect a patient has a septic process, you're going to want to get blood cultures. And then also, as I mentioned, an arthrocentesis can be helpful, but that would require, I think, a rheumatologic referral. And some places don't have rheumatology consultations, and orthopedics can do this, although they don't really like to see patients just simply for the arthrocentesis. Most physicians can learn pretty quickly to do a knee arthrocentesis. So if you see a lot of patients with joint pain, you might ask one of your buddies who is an orthopedist to show you how to do an arthrocentesis. And then we also have x-rays. Now I'm just going to show you a few x-rays. I can't possibly go through the entire radiographic manifestations of arthritis, but here's some coming up that will be helpful. First, I wanted to mention briefly that synovial effusions can be helpful when they're evaluated in the laboratory. Septic arthritis is the one of greatest concern, and there's often an overlap between septic and inflammatory. And you want to get a differential, and you want to make sure that you send the fluid for culture. This non-inflammatory would be the osteoarthritis, and normal, it's just very clear, viscous, with hardly any leukocytes. Now, the x-rays of osteoarthritis will show characteristic joint involvement of the joints that you would expect to be involved. And the radiographic findings would be hypertrophic spurs, subchondral sclerosis, joint space narrowing, which is asymmetric in hips or knees. So if you see the knee involved, you're going to see just one compartment of the knee often. And then there'd be characteristic malalignment, particularly in osteoarthritis, as I mentioned. So this is a normal knee x-ray. And this is where the cartilage is that I showed you in that schematic. And this is asymmetric joint space narrowing. In fact, it almost looks like there's corresponding increased joint space as the joint became more narrow here. In contrast, if you look at x-rays of knees, you see that the joint is very symmetrically involved, and it appears that the joint space is pretty narrow. And that's because the synovial tissue that's all around the joint is involved and is producing this type of radiographic change. This is a patient who has cloudiness where it's supposed to be black. Whenever you see that, you think about chondrocalcinosis. And chondrocalcinosis basically means calcification of the cartilage. This patient, you can't diagnose quote unquote pseudo gout without taking the fluid from the joint, looking at it under the microscope and seeing the crystals. But this patient has a high degree of likelihood of having pseudo gout or some of the other syndromes associated with chondrocalcinosis. Let's see, I'll run through real quickly some facts and figures about gout, and then we'll call it a day. So gout is called the disease of kings and the king of diseases. And this is the very typical presenting finding in patients with gout. Usually it's a man. very uncommonly in premenopausal women. And I'm saying some things over so they'll stick. The first MTP, I'm sure all of you remember from medical school, is the most commonly involved joint. And you get a sense that there's fluid in there that's just bulging out. And the same is true here with the ankle. And you can actually take a needle and stick it into the MTP joint, pull a little bit of fluid out. Sometimes you'll get into a tophus, which is a subcutaneous collection of fluid, and it'll be like white toothpaste that kind of oozes out from the joint. It's kind of gross. Now, the crystals have particular characteristics. This is a white blood cell here in the background. And here's a very brightly refractile crystal. And what you want to do is you want to have a polarizing microscope that shows you look through the microscope and then you establish the way that the microscope is polarizing, and you compare it with the orientation of the crystal. So if the microscope is polarizing this way, then this crystal is said to be parallel to the plane of polarizing light. Now, this very same crystal is going to turn blue if you rotate it 90 degrees, because it will be perpendicular to the plane of polarizing light. Now, this crystal, and you notice it's a needle-shaped crystal, and this crystal is very different because it's hardly evident. It's very weakly birefringent. And here we see that the plane of polarizing light is going right to left. And this crystal is actually also, like this one, parallel to the plane of polarizing light, but it's blue. So it's diametrically opposite. And this is a calcium pyrophosphate crystal, which is the cause of quote unquote pseudo-gout. This is a great picture of Henry VIII fiddling, and gout is there's a whole series of slides of paintings like this, prints like this, that are kind of fun to look at. You can see the booze or the wine, red wine, which is associated with it too. So it's distinct from OA or RA because it's acute within hours to days. It involves the first MTP joint more than 90% of the time over time. It's one of flares and remission. Uric acid is elevated most, but not all the time. Dietary factors, alcohol, hypertension, chronic renal insufficiency, and associated medications are important. Male more than female. So let's go back to our patient. Doctor, do I have arthritis? So he is a 45-year-old male, history of IV drug abuse, history of bilateral hand pain with apparent inflammatory arthritis involving his MPs and PIPs, and he had a lower extremity rash, which was typical of leukocytoclastic vasculitis. So I can't see you, so I don't know what the show of hands might be, but this seems to me to be unlikely to be RA, unlikely to be lupus. Could be hepatitis B, but hepatitis B doesn't usually cause a purpuric rash. So I would say that this is highly typical of hepatitis C. So without doing too much other than just ordering hep C test and excluding with a few other blood studies, we took a history. We found out he took drugs. We looked at his rash. Exam suggested synovial swelling of some inflammatory type joints, and we've made our diagnosis. These are some references that you might want to take a look at. And again, I want to just leave you with the notion that the history and the physical exam still in this particular circumstance are critical, A, and B, you need to be the patient's advocate. And if there's any question about whether you need to refer the patient to a rheumatologist, do so. And I would urge you to call if you believe that the patient needs to be seen in other than just a routine way, because nobody else is going to be able to advocate as well as the person who sees the patient. With that, I'll stop. I can't believe I talked so fast that I got through this talk in 55 minutes, but I did. And anybody who might have any questions, feel free, raise your hand and we can take those questions.
And while we wait for questions, I'm going to put a couple of things in the chat. Please put any questions in the Q&A.
Well, if there aren't any questions, there probably will be as you start to use this type of approach to a patient. It really doesn't take so long to develop the ability to ask the right questions and get a good sense. And that's really what you really need to do. So let's see. Was that thing in the chat? Was that you?
Yes, I just
Okay.
put a reminder about the survey. It'll appear in a tab when you close out of the webinar, but we really appreciate you taking a few minutes to complete this. Not only does this give you SAMI credit, but also helps you to plan the best session for you. We share the feedback anonymously with the speakers, and they greatly appreciate your thoughts.
Yeah, I want to encourage you to do that too because I read them and I can respond to you and the next group that I give this talk to. Presumably there will be others. I can change my approach or include some other things if you're interested in hearing it, that sort of thing.
And we
And
just
also, I want to put a plug in for the other um, uh, talks that I do, and I'd be happy to speak with y'all again on another occasion. So just contact the MAVEN schedulers and they'll do it. Okay?
And there is a question, what
Sure.
percentage of PTS with gout have NML uric acid?
What percentage of what?
It says PTS with gout patients with gout, I guess. Sorry.
Okay. I don't know what patients. Yeah, what
Yeah,
percentage
sorry.
of gout have elevated uric acids?
Yes.
Well, if you took if you were able to order a uric acid every day or every month or every week, basically it would be roughly 100%. It's just, in other words, they do have hyperuricemia at some point, but the percentage is certainly nowhere near 100% in patients who come in with an acute joint. In fact, sometimes they paradoxically have lower than normal uric acid when they come in with an acute joint. So um, it it's interesting over time to look at their uric acid level, and one of the treatments for recurrent flares is to drop their uric acid level below usually in the 3 to 4 range, and it should reduce the frequency of flares in most patients. But um, it's close to 100%. The answer is close to 100%, but not at the time of the acute flare. It's as you follow the patient over time. Does that answer the question? Anything else?
I don't see any yet. I did put a couple other things in the chat. I did mention education sessions. So we hope you enjoyed today's session and are interested in attending future sessions or even anchoring an educational session. All clinics can anchor an educational session, which means you get to pick the topic, date, and time of an educational session. The only requirement is that someone from your clinic attends the session. If you're interested in becoming an anchor, we would love to schedule your session. You can either submit the educational session request form on the clinic portal, or you can email ktalbot@mavenproject.org. So I did put that in the chat. And we have 6 minutes if anybody has any questions. And I mean, I'll keep going, but I'll mention one more thing while we wait for questions about our mentoring program. It's just a reminder that MAVEN Project offers mentoring to all of our community providers at any point in your career. Some topic ideas to reference: new to practice providers, challenging case review, preventing burnout, building teams, and executive coaching. Also, we offer specialty-specific mentoring like EKG or CGM, or reference the topic of today's ed session. So again, that's all those things are in the chat, but we can wait a couple more minutes if anyone has any questions.
Well, if you have questions tomorrow, just send them to the MAVEN folks, and I'll be happy to respond down the road. But thank you all for joining, and I wish you, I hope the weather in California is just as pretty as it is here, and hope the fall season is good for you. So thanks a
Thank
lot.
you. Thank you so much, Dr. Upchurch. It was a great presentation, and thank you to everyone who attended. I hope you all have a great rest of your day. Bye.
Bye.